Let's get going with our presentation. Please let us know if you can hear us, and you can hear Dr. Tsakos as well. Okay, and here's the presentation right here.
Okay, hi everyone. Sorry about the issues tonight. Please chat, put on the chat if you can hear me okay, because my I seem to be frozen on my screen. Can you hear me okay? And also, I can't see my presentation. It's not a very good night. I'm sorry about this.
Okay, can you hear me okay as well or not?
I can't see my presentation, Caroline.
And can you hear me?
Yes, I can hear you and I can see the presentation now.
Okay, perfect.
Lovely.
So maybe the slides will be slow, will go slow, but of course everything is working. Yeah. So let's try to continue. Hopefully it's going to be all okay.
Heather, Aid and Photios and David, thank you thank you for notifying us that you can hear us. So, okay, we're starting a little bit late, so I will try to catch up and I will try to give you as much time as possible at the end for questions. And of course, as a tiny compensation, you're free to send any private messages, and I'm very happy to offer you free consultation afterwards if you wish at a later date. I mean, I'm really sorry. There's some issues now with internet by the looks of it. So I'm just trying to scroll to the second slide. Okay, so we're going to discuss about advanced maternal age. What's the definition and main issues? What are the options for advanced reproductive age? In my opinion, is the better term. And what are the main options and what are the supplementary options? So advanced reproductive age, what's the definition and what's the fuss about it? I mean, in most scientific textbooks and journals now we find that 35 plus is the age of the beginning of a definition of advanced reproductive age. Having said that, I mean, it's becoming more and more common to be facing with women, singles or couples in that age group. And to be honest, in my practice, the average female age of patients seeking our services is just under 39, 38.8 months. So we know that after the age of 35, the chance of conception is lower, and that affects both natural fertility and also assisted reproduction techniques. And also there's an associated risk of adverse outcomes. But this is the population we're dealing with. And especially in the last 4 or 5 years, because of COVID, because of all the restrictions we've had, some women who were like bordering on that edge, now they've been pushed towards late 30s or early 40s. So we have to face the fact that most of our patients eventually will be in this age group. And there's a lot of reasons why, of course. So why is advanced maternal age an issue? Please feel free to copy the slides. I mean, I was very fortunate to collaborate with my colleague, Dr. Manos Xidias, and we put together this presentation, and I will try to make it as graphic as possible so that you can take a little bit of take-home messages. So why is it important? Genetic anomalies, that's for sure. So basically, the chance of a genetic anomaly leading to either failure or miscarriage or abnormality is more likely. Diminishing fertility, and this affects the overall female system, not just the production and the quality of the eggs, and also the increased maternal risks. So associated factors with age, which include either pathology, uterine pathology in terms of fibroids, endometriosis, infections, cervical anomalies, and so forth, are more likely to happen in advanced reproductive age. And equally, general medical conditions like diabetes, hypertension, obesity, moderate or severe obesity are more likely to affect women in this age group. So we're not talking just for lower chance of success, but we're talking about a higher risk of miscarriages as well. So what happens to the ovaries? there is a reduced ovarian reserve. We know that. I mean, it's been known for decades. So this is the ovarian reserve. These are the ovaries and the follicles and the potential eggs of a young woman in her 20s. These are the follicles and the potential eggs of a woman in her mid 30s, and these are the ovaries of a woman in her late 30s, early 40s, mid 40s. So as clear as that. So a very, very straight line in terms of diminishing the quality. Also the function, the quality, not just the quantity, but the quality of the oocyte is diminished with advanced age, and there's a lot of mechanisms through which this is actually happening. And the overall fertility. I mean, overall fertility is a combination of factors, which include the quality of the eggs, the function of the egg, the function of the reproductive system, of the fallopian tubes, of the endometrium, of the uterine cavity, but also the function of the body as a whole. So that's why overall fertility is declining. The beginning of the decline starts in the late 20s. There is a crucial moment in time at the age of 35. And then, of course, it's decreased even more after the age of 40. And it's also almost disappearing after the age of 45. And we're always talking about fertility with own eggs, be it natural fertility or assisted fertility. I mean, a common misconception with women, especially in my region, in the South European, region, in the Balkan region, a common misconception, unfortunately, is the fact that, okay, I will try my best for natural fertility, and then when I'm in my early to mid or late 40s, I will resort to IVF. So we have to make it loud and clear that when we say that the overall fertility is reduced, the same applies to natural and assisted fertility. So, we have to bear in mind that IVF success rate mainly depends on the female age. That's the main factor that determines the success of assisted reproduction technology. And of course, one of the factors also that's adversely affecting women in this age group is the increased miscarriage rate, which may be due to a combination of all of that, plus other additional factors. So overall, the take-home baby rate, and that's why is reduced, and that's why you can see various definitions of success by various clinics and various doctors and various statistics. And I mean, at the end of the day, this is what interests our patients more than anything. What is the chance of taking home a healthy baby? And this chance is seriously reduced in women of advanced reproductive age, more so in women over the age of 40 and over 45 for that matter. So genetic anomalies, more or less everyone is familiar with that. The incidence of anomalies is increased with advanced age, and of course most of you are familiar with Down syndrome, which is linearly associated with female age and with male age as well, I have to say, although the effects are starting to become more evident after the age of 40, 45 or 50 in men, but also other anomalies like trisomy 18 and so forth. So not only less oocytes, but also less quality oocytes, which they may or may not implant, and they're more likely to produce embryos with abnormality. Okay, so internet keeps playing up here. So what are the general health concerns? And of course, this is a huge chapter in obstetrics, which is the preconception care, which is the assessment and the evaluation and the counseling we should be doing to women wishing to become pregnant, women of any age. But of course, the effects of aging on general health is broad and wide. So chance of malignancy, In my unit, we have a very, very strict screening program and protocol. No woman, regardless of her age, is going through IVF unless she had a thorough breast assessment. And when I say thorough breast assessment, that is not just palpation, that is not just history, that includes imaging by means of either an ultrasound scan of the breast, specialized ultrasound scan of the breasts, regardless of their age, I repeat that, mammography, or both. We are very, very strict on that for various reasons that go beyond the scope of this presentation. And sadly, or perhaps not sadly, we diagnose about one breast cancer every 6 weeks, roughly. We diagnose about 7 to 8 cases of breast cancer every year, and that includes women. I mean, recently we had a 38-year-old doctor. 38-year-old doctor. 38 is before the screening time for NHS, for UK screening protocol. I mean, this woman, if she'd lived in the UK, she would have had IVF, and if she'd gotten pregnant, she would have delayed her diagnosis of breast cancer by about 2 years with pregnancy and breastfeeding. So we're very thorough in this, and I think that it's our obligation when we are to give even a sniff of hormones to a patient. We need to ensure that there's no tumor lying somewhere that would be exploded with the use of hormones. And of course, hypertension and cardiovascular risk, metabolic syndrome risk, thrombotic risk. That's a huge chapter. We have been, in my unit again, we've been very fortunate because we've been involved with some hematology consultants many years ago, and we have acquired a little bit of sensitivity in terms of assessing the thrombotic risk, whether this is congenital or acquired. I mean, thrombophilias are commoner than we think. Even innocent thrombophilias, like a small sort of tendency, may be important in a woman of advanced reproductive age. Excuse me, especially in view of ovarian stimulation and hyperestrogen activity, and also in view of potential pregnancy. That could be a serious issue as well. Cervical pathology, HPV testing, very important. I mean, it's part of our screening now. Before we start IVF, we don't just perform a standard pap smear, cytology smear. We also test for HPV DNA in order to identify those high-risk women. Thankfully, there's only 5 or 10% of them that may be potentially high risk, but that's still a big percentage who require a specific attention. So for all of those you out there, I mean, just remember that as you wouldn't start the tour of Europe in your car without a major service, it's not perhaps wise to start a fertility journey without a major and serious assessment of all those risk factors that not only may be associated with success or failure of IVF, but they may also be associated with success or failure of pregnancy, and also with your general health and well-being. And the same applies with uterine dysfunction, fibroids, adenomyosis, endometriosis, uterine polyps. Women of advanced reproductive age, in particular women of the age of 40, the chance of having some sort of uterine pathology is pretty high. How high? Maybe 50% high. Of course, the question is how important it is. And the answer is that, in my opinion, again, after 30 years in the field, I feel that the uterine cavity has to be perfect. And it has to be perfect for 2 reasons. One is for the health of the woman. Again, every year in my unit, we're a medium-sized unit. We're not a huge unit. We perform about 500 cycles a year. And every year we diagnose 1 or 2 cases of cancer, uterine cancer, either through a polyp or through a fibroid. That's a lot, in my opinion. So on average, if the risk of uterine cancer is about 1 in 250, you can imagine how important it is, especially in larger units and so forth. And of course, the more advanced the female age is, the more likely it is that we may find something that is important. And equally, it may be important for the success. I mean, there are some conflicting reports in the literature. I mean, I'm a great believer of hysteroscopy. I feel that, I mean, in my times, in the early 90s, and I was trained by some amazing people, by you know, I've been the dwarf on the shoulders of many giants in the field of fertility. And at the time, you know, no one would go through IVF without laparoscopy and hysteroscopy. And now in 2023, the majority of women go through IVF without any formal assessment of the uterine cavity or of the tubes and so forth. So I think there is something missing there. So it's a long discussion. Of course, not all fibroids need to be removed, of course. But in my opinion, the uterine cavity, at least the endometrium, has to be visited, even if there's no suspicion on the scan, because something like 20% of small polyps are not visible by scans, even in the best of hands. And they have to be addressed, treated, and sorted out with biopsy and all that before we move on. And of course, lifestyle factors, very important, very important. 5% here, 10% there, 15% there would give us the optimal expectancy of success rate in our time. I mean, there's no point using time-lapse technology, using the most extreme air cleansing in our labs, using the latest equipment, using the latest technology of scanning machines. I mean, I never cease to be amazed by the newest technology in scanning. I mean, 25 years ago, we were imagining the female pelvis, and now we can see it, 2D, 3D, 4D, Dopplers. So, we can take slices, we can use AI on the follicles, on the uterine cavity. Amazing stuff. I mean, the evolution of scanning is amazing, but there's no point using that on someone who is seriously overweight, with terrible diet and so forth. And of course, we have to assess the maternal and obstetric risk. We have to discuss all of that. We have to address all of that, especially now that we're pushing the boundaries of fertility really forward. I mean, in Greece recently, there's new legislation that allows, under conditions, of course, women up to the age of 54 to proceed with IVF. So you can imagine the responsibility that we have to identify those women who would be in dire risk if they proceeded to IVF without modification beforehand. But of course, you can imagine the responsibility if something goes terribly wrong, which may do. So we have to be very careful. So we have to balance success with safety at every given moment. So I think I missed a slide here. So the effect of age, obstetric risk. So I'm not going to go through obstetrics. I mean, thankfully, the obstetric teams are getting better and better, but all the pregnancy complications are much higher. And again, here I cannot stress enough the value and the importance of single embryo transfer. We should be aiming at absolutely minimizing, if not eliminating, multiple pregnancies over the age of perhaps 40, and overall for that reason. So because all the complications, of course, are much higher. So what are the primary fertility options? This is my amazing embryology team from Embryoclinic, and I'm very grateful to them because they are, they're the chefs and we're the waiters. That's how I feel. And waiters seems to be getting most of the tips, and the chefs just there doing all the work. So I'm very grateful to the embryologists, not only the embryologists that you can see, but also the ones that are behind the scenes. And I can't thank enough an amazing guy who's always there supporting in every possible way, and that's Dave Gibbon. So thank you, Dave, for everything you've done in the last 30 years of my journey in this field. So fertility treatment, pre-IVF testing, very important, very, very important. I mean, just like an athlete would never dream of going to play the game without prior testing, trying, assessment, exercising and all that, and optimizing. Similarly and equally, we're under a lot of pressure to treat women tomorrow with the next cycle. Oh, my period is due next week. I had booked my holiday and all that. It's a tremendous pressure that perhaps we have to resist on. And also, we've been very bad, us medics, we've been bad in stressing our patients. So every month is important, especially after the age of 40. If it goes 2 months down the line, 3 months down the line, something horrible is going to happen. I don't think something horrible is going to happen, to be honest, regardless of how old you are. If you wait 2 to 3 months to optimize yourself physically and emotionally before you embark on this journey. So pre-IVF testing and counseling is extremely important. We have to sit down with you, you have to listen to us, and we have to listen to you in order to understand your expectations, in order to understand your family situation, your support, and everything before we embark on the treatment. So, of course, IVF ICSI is there, long discussion as to which is what and for which patients. And of course, then we have oocyte or embryo donation, lots of options for our patients, tested, tried, successful. And of course, I keep saying that there's no woman, there's no single woman, there's no couple who cannot achieve a pregnancy if they go all the way. And of course, the end stop would be the surrogacy program. I mean, with surrogacy, effectively everyone can achieve a pregnancy. And of course, this is a very complex program that we would resort to under very, very specific indications. So pre-IVF testing, take a screenshot of that. The basic testing, which we can see on this side, the a little bit advanced testing. I repeat that I am a big fan of hysteroscopy. I mean, I think at least we can do a hysteroscopy. At least we should be doing some sort of X-ray assessment. I mean, recently we had this amazing couple from England who had blocked tubes. Normally with blocked tubes, we say, okay, they're blocked, so we don't care if they're blocked. They're not hydrosalpinges, so it doesn't matter. Somehow we had some levels of suspicion about potential infection, so we performed a laparoscopy on that woman, and we found that she had very serious pelvic infection that threatened her life, not just her fertility. And of course, if we ever dare to implant an embryo in that environment, the chance of failure would be perhaps 90%. And if there would be any chance of implantation, there would be no chance at all for this pregnancy to go to term, and it would put through immunosuppression of pregnancy the health and the life of the woman at risk. So always think, dear patients, dear colleagues, dear associates, dear stakeholders, dear health professionals, always think, am I 100% sure or 99% sure that there's nothing untoward in that pelvis, that there's no endometriosis? I mean, even mild to moderate endometriosis which was not visible on scan. I mean, I would like, please, to give a lecture on endometriosis and infertility at some stage, because I think we underdiagnose, we undertreat, we under-evaluate, we under-consider endometriosis. So very important. Microbiome, that's the new kid on the block. Specialized testing, I mean, it's not in my first line investigation, but certainly we have to keep it in mind, especially if there's repeated failures and unexplained failures. I mean, okay, when you have a 43-year-old woman, 44-year-old woman with moderate or sort of average quality blastocysts who doesn't get pregnant, once or twice, perhaps we may not look for microbiome. But if we have top quality blastocysts on a fairly young couple and unexplained failure, then we may need to look in the microbiome, in my opinion. And of course, genetic testing, very important. And again, I'm not going to go through that, but pre-IVF testing is very important. And again, in my opinion, this is a pyramid. When we start with a couple initially, perhaps we don't go very far with this assessment on this side, but the more difficult the case becomes, the more we have to dig deep inside. And one of the latest kids on the block again is also the value of PRP in the endometrium. I mean, my team have not tried it yet. Until now, we hadn't been convinced about its value, but now it seems that there is some evidence that endometrial PRP, especially for cases advanced reproductive age, with thin endometrium, with implantation failures, with miscarriages, with adhesions, may be of some value. And there's a couple of meta-analyses and reviews that prove a point there. So IVF-ICSI, I'm not going to go through the details because I really want to give you time for questions. You're all familiar with IVF-ICSI. Oocyte donation and embryo donation. I mean, if the sperm is normal, and again, there's a huge question mark, what is normal in a sperm? I would also like to, to give you my perspective, the gynecologist's perspective on sperm. All I have to say is that if the sperm is hunky-dory, then perhaps if we don't have, failures, or if we only have 1 or 2 failures with good embryos, perhaps we shouldn't be looking at that. But if there are question marks about sperm, there's a huge science behind exploring semen analysis and sperm parameters and assessments of male infertility that we have to look at. I mean, there's all sorts. We're learning every day, every week on various areas of male infertility that we haven't known until recently. So let's not completely ignore males. Let's not completely simplify the assessment of male infertility. But anyway, this is not for now. So oocyte donation is there, embryo donation is there if we're not happy with the quality of the embryos or if we've had lots of failures, and of course surrogacy. Surrogacy is the last resort, in my opinion, when we've tried everything, or when there are factors like malignancy, like Rokitansky syndrome, like multiple fibroids or hysterectomy, and there's no chance of carrying their own baby. I mean, I haven't put it in my slides because, again, this is a little bit of a new project that my team and I are entertaining, and we're hoping to be able to present you this in the next few months. There is also now, it's becoming, I wouldn't say popular, but it's becoming evident that uterus transplantation is here to stay. More and more reports are coming from all over the globe, and it seems that Europe, and especially the Swedish team, they have the lead in that. I'm trying and I'm hoping to be able to connect with the amazing people who perform uterus transplantations in Europe. And it is my fertility, my surgical and my IVF feeling that perhaps in the next 3 to 5 years, uterus transplantation will be more available, more successful, and more of a real option for patients all over the world before gestational surrogacy or together in this category, if you like. What are the supplementary options? All sorts, pre-genetic testing. I'm not going to go through detail because I really want to take questions. PRP for ovarian rejuvenation. They have, again, my team have been looking hard to see for a little bit of an evidence that would convince us to be involved. At the moment, we haven't been involved, but we're hoping to extract some evidence to identify perhaps a subgroup of population. There's a huge study now going on in Germany, prospective randomized study on PRP ovarian rejuvenation. Unfortunately, the results will not be available until 2027. We're hoping to have some preliminary results, and also our research and development team are starting hard to compile all the evidence in order to identify perhaps which subgroup of patients would benefit and exactly what type of rejuvenation we would be offering to our patients, given, of course, the fact that we're not sure whether it works or not, and that the evidence at the moment is not very solid. Hysteroscopy, I mentioned that. I'm not going to go through that, but to my mind, in my experience, and in the literature, it seems that it is helpful, and it becomes even more of a solution many times in women of advanced reproductive age. And of course, robotic surgery is here to stay. It's been around for over 20 years now. Again, my team have been fortunate enough to be applying this for the last 4 years. We've had some amazing results in our series, and also we've recently reported in collaboration with the universities of Greece and of Italy. We've published review and meta-analysis outlining the benefits and the advantages of robotic surgery, not only versus open laparotomy, but also versus laparoscopy, which had prevailed in the treatment of fibroids in the last 20-25 years. So robotic surgery is here to stay. The fertility benefit also seems to be substantial. And of course, all the other advantages of minimal invasive surgery. And the main advantage versus laparoscopy, as proven in our study, which has become very popular. Because of this study, we have been awarded by the European Fertility Society, and that was a very proud moment, an unexpected moment in Copenhagen a couple of months ago. And also, we were called to present the paper in the European Society of Gynaecology Conference, which effectively the main advantage of robotic surgery is the fact that it has 50% less chance of converting into laparotomy versus laparoscopy, and together with all the other additional factors associated with reduced blood loss and reduced pain and better outcomes, as you can see on this slide, which was the conclusion of our study. So take-home message: advanced reproductive age is more and more common in assisted reproduction technology. Women of advanced age have poorer fertility outcomes and higher risk of adverse outcomes. That's why we need to pay even more attention on them. We need to do more and more in terms of counseling and pre-IVF before taking those women, those couples on board. There are multiple options, and which option we discuss and we choose depends on individual indications. And of course, there's a plethora, there's an abundance of supplementary outcomes as methods in order to improve the outcomes. That's a little bit of literature here, so feel free to copy that. And I'm very grateful to this amazing team of 30 amazing individuals, smiling, happy, inspiring, young, very young. I'm very proud of all of them. They work very hard to put together all the evidence every day, to challenge me, to correct me, to guide me, and to keep me, happy and enthusiastic after 32 years in the field, and hopefully to change people's lives. Thank you very much. I'm open to questions.
Thank you so much indeed, Dr. Tsakos. As always, it's been a great presentation, and of course, it's been great to hear from you, and it's always inspiring for sure. And now we will go for your questions. So if you haven't asked your question yet, go ahead, type this in, and there are some questions ready right here. So let's get going with those. There are some with some of the details, so let's have a look at the first question. So what kind of stimulation protocol do you recommend in older women with PCOS? Do you use Clomid or Femara? I'm 51, but my MH is still 5.6 nanograms per millimeter, FSH 4.4, LH 4.2, prolactin 6.4, estradiol 111.6, and I don't have high testosterone. Last AFC was 26. I get a lot of eggs with FSH only protocols, but they are immature. Last round I did estrogen priming and added LH to protocol, but got only 4 eggs. 2 of them fertilized, only 1 blastocyst. Let us know if you can advise here.
Hi, Polona. To be honest with you, I have no experience of stimulating anyone in your age group, so I don't know. It's fascinating. Your hormonal profile is fascinating. I don't know. I have no answer to this. I mean, all I want to say is that, to my knowledge, the oldest woman in the literature who conceived after IVF with her own eggs has been 46. I have been discussing with my colleagues all the time. Some of my colleagues, they say, oh, I've had a 47-year-old, 48, but no one has published them. So we have to stick that to the fact that, to my knowledge, there's no one, not a single person in your age group who has had a successful delivery of a healthy child So I'm afraid the overall chance, whatever we use, has to be extremely small. On the other hand, to be honest, I would be seriously interested in you, because I've also equally haven't seen ever in my life anyone in your age group with such hormonal profile. So I'm sorry I can't help you, specifically. I would be very skeptical in stimulating someone in your age group. I don't know if you have been counseled with regards to your chances of pregnancy, the chances of miscarriage, and all that. If I were to treat you, to be honest, I would definitely consider PGTA, because the chance of producing again a blastocyst that is healthy, chromosomally healthy, is perhaps very low. So I wouldn't want to transfer blastocyst that it's unhealthy. So I don't know if I've helped you, but yeah, you're a fascinating case that I've had no previous experience with such age group with such characteristics.
That's understandable. Thank you so much. And of course, thank you for your question. And let's have a look. This is an interesting question. And the patient is asking for your opinion here. So, manipulation practices on embryos microsurgery in microsurgery. Sorry. So, every embryology lab director should be a clinical MD embryologist in terms of international medical ethics and medical law to protect embryo rights, institutions, and parents. So I strongly support embryology residency programs like Turkish and French residency programs. What do you think?
Well, Bahar, I have no opinion. I mean, I know that, I mean, in Greece, for example, they have to be embryologists. So they have to be either qualified biologists or geneticists who have done specific training on embryology. In Greece, I'm also very, very familiar that in other countries, I'm not going to name which countries, they can be just technicians. So anyone with a little, some sort of degree as a technician, as a lab technician, may perform ICSI and just that. I feel that there is a lot of variability. I mean, I don't know what's right or wrong. I mean, in my opinion, it has to be done perfectly, and there's a lot of key performance indexes that we can look into and decide if somebody is good at the job or not. So I think that's what counts. But in Greece, as I say, in my country, they have to be biologists or geneticists with
Right.
specialized training.
All right. Thank you for this as well. Of course, thank you for reassurance here as well. And let's have a look. We have another question from a patient who would like to know which grade of cervical pathology would be acceptable for IVF. Would you see it, which is not mandatory to be operated in Germany, be acceptable? And what about HPV? Possible to go through IVF with a positive HPV result?
Sure.
HPV
Sure.
16.
Lou, thank you so much for your question. I mean, firstly,
Sure.
all I have to say is that unfortunately, the majority of women going through IVF, they have no clue about the HPV status. And when I say the majority, I would say, less than 10% of women, they know their HPV status. And of those women, perhaps, I don't know, overall, perhaps 10, 20%, 15%, depending on the age group, depending on where they live, may have high risk HPV. So I think in this case that you're describing, it's fortunate that this has been diagnosed, because we can only manage what we know and we can't manage what we don't know. I mean, my answer is very clear. I would just consult the gynaecology team, the gynecologist team, and I would take their opinion as to how to manage that. I mean, I don't think it's a matter of accepting or not on IVF. It's a matter of understanding the importance of the result. I think it's 100% important to have 100% diagnosis before we do the embryo transfer. So maybe colposcopy, maybe mRNA HPV testing, maybe even biopsy, maybe of value. So that at least we know that we're starting off clear. And then, of course, the gynecology team, the gynecology team may may well give us in collaboration the protocol of following up. Another point I would like to make is that again, there is a little bit of a point there in classifying this patient as a high-risk patient, not only in terms of developing a cervical pathology, but also in terms of potential cervical insufficiency, because there are some reports saying that recent and even old HPV infections may affect the integrity of the cervix, and they may be associated with premature labor or late miscarriage. So again, I cannot stress enough. So congratulations for finding this out. I repeat, the majority of women are not aware of their HPV status before they embark on IVF, and I think they should, especially women of advanced reproductive age. And as long as you know that, you have more chances of managing it properly.
Okay, brilliant. Thank you so much indeed for your question. And there's one more from Lou. So let's have a look. So what to do from your perspective if factor 8 and only this one, which doctors say are not mandatory sign for thrombophilia, right, is above the norm? What about that?
Yeah, okay. Long discussion. Okay, I mean, there's an entire specialty. It's hematology, and then hematology, which is a medical specialty, is divided into fertility hematology, because there are hematologists dealing with cancer, with thrombosis, with CVAs, with MIs, and some hematologists a little bit more familiar with fertility. I think each one of us, they have to be connected with some sort of hematologists in order to jointly manage this case. Generally, the answer is depends on the rest, depends on other factors, on the age. I mean, the value of this, the importance of this is different if you're 34 and if you're 51. It's different if you have a normal BMI or if someone is obese or seriously obese with a BMI over 35. So long discussion. I mean, we would look at it in the context of the general case rather than in isolation. And also has to do again with the protocol we use. Are we going to use standard stimulation or mild stimulation or no stimulation in a natural cycle or just frozen embryo transfer, and so forth. So it is something that, again, it's I think it's beneficial if we know it, because again, 90% of women, they have no clue about their thrombophilia status. I'm not saying that you have to run tomorrow and run a thrombophilia check, but anything we know, we have more chances of dealing with appropriately.
Okay. Again, thank you so much. And there are three more questions from Lou. Let's have a look. Okay. So in my hysteroscopy, there was a possibility for adhesions, but there's no certainty about that. At the same time, my endometrium is always between 7-11 millimeters at the moment of ovulation. Does such an endometrium exclude adhesions from your opinion or not? And can adhesions prevent implantation, I think.
Yeah, sure. Okay, to be honest, I'm a little bit concerned about the variability between 7 and 11. I mean, 7 is borderline normal. 11 is, again, borderline normal, could be hyperplastic. So I'm not sure this variability is something that, I don't know how to interpret that. Definitely adhesions you either have or have not. If there's a doubt, you probably haven't, to be honest, because if you have, you have, and so forth. So I don't know. Very difficult. I cannot answer that. I mean, basically, if you have some images for someone to review, or preferably the whole video of the video hysteroscopy, I'm sure maybe going back to your doctors, they should be able to reassess whether you have adhesions or not. Adhesions are, may be variable. They could be flimsy, tiny, or they could be dense. They could be, widespread, or they could be localized. I think it's important to understand what we're talking about. before we
Mhm.
go any further. If there's any query, I think a repeat hysteroscopy may be in order. I mean, in my mind, the hysteroscopy is probably valid for a year and a half, especially in women of advanced reproductive age over the age of 40. And especially if in the meantime women have had perhaps failed IVFs or miscarriage or DNC or and so forth. So hysteroscopy is not a big deal. I mean, it's a diagnostic procedure. It's a little bit more than a scan. Could be performed as an outpatient. You don't always need a anesthesia. You can have a flexible hysteroscope that you just have a look inside with minimal discomfort and minimal, minimal issues. So I think if in doubt, have another hysteroscopy.
Okay. Again, thank you so much. One more, actually, from the same patient. So, from your experience, how big is improvement achieved by PRP?
I
Anything you
have
can?
no personal experience. I'm hoping to acquire some, but I'm
Mm.
being, despite the fact that our team, is probably considered a little bit innovative, with technology. We were amongst, at least the first ones in our region to employ 3D scanning, 4D scanning, all that, robotic surgery. We're a little bit of technology freaks. However, we have been a little bit slow in adapting. In adopting the PRP technology, perhaps because evidence is not very sound. I don't know. I have no experience whatsoever.
Hmm.
Um, I think that maybe in the endometrium for certain indications there may be a value, and also the safety profile is very good there. There's nothing that can go wrong with endometrial PRP. And as I said, there's a recent meta-analysis which is proving a benefit in some case of women. So we're hoping to be able to identify a protocol and use it. Ovarian PRP, no idea. We're hoping to be able to get some data from the existing studies and be able to publish a review and meta-analysis hopefully soon. And also, if the Germany group, who are performing an amazing study at the moment, prospective randomized study, if hopefully they have some preliminary data in 2024. So at the moment, no idea.
Okay. Thank you
And
so much
we
indeed
are,
for
if I can
sharing.
make a comment on PRP, I think, it's, I think we have been a little bit ahead of ourselves, as many times is happening. I think people are employing PRP. Okay, it's an easy procedure, it's inexpensive, we can do it, why not? But in my opinion, I think we should be a little bit careful in employing techniques that have not been fully proven.
Mm.
Uh, and if we do, at least it should be in the context of some sort of clinical trial, or in the context of a consent that includes the fact that we're not entirely sure, and we're not promising miracles to our patients.
Mm. Of
So
course.
I think our patients need to be fully counseled, and they have to be consented for the fact that the evidence at the moment is not very sound there.
Okay. Thank you so much indeed for sharing your opinion on this as well, of course. And let's have a look. Let's change the subject a little bit. So, do you have any views on low testosterone? I'm 41, but already at age 36, my testosterone was practically zero.
Okay, I think Lou, you have a lot of questions and
For sure.
very difficult ones as well. Uh, okay, I mean, there was a theory about testosterone, and to cut a long story short, recent studies have shown that adding testosterone um, hasn't provided any benefit. So, um, okay, I think again we have to look at into the general context. So, um, we have to look at generally the hormonal profile. Um, you know, Taking into account the general hormonal profile, the derivatives of testosterone, other factors, the LH, the phase of the cycle, other factors, and all that. But um, unfortunately, adding testosterone or pre-treating with testosterone before ovarian stimulation has not been proven to be helpful.
Okay. Thank you. Thank you for this. And let's go to the next question we have here. So it was skipped, but it's right here, of course. So how many failed IVF cycles is too many? I've had several complete fertilization failures, empty follicles. I've had 8 already, all high stimulation doses.
Sure. Well, Lynn, depends is the answer. I mean, in my mind and in my practice, I try to, not to stay at, not to use the same thing all the time. So, if, for example, if it seems that you've had multiple stimulations and eventually no embryos. So, if that happened once or twice, then it's probably the time to move on to natural cycles or modified natural cycles. I mean, if with maximum stimulation you produce one or no follicles or no healthy eggs or no healthy embryos, then there's no point. There's no point in stimulating. You'd rather go. Sorry, I just opened the window. It's 25°C in Greece at the moment, so it's pretty hot. So move on to mild stimulation. I would just use perhaps either clomiphene citrate, or letrozole, either alone or in combination with small dosage of gonadotrophins. FSH, I may add a little bit of LH, but on a small dose. I mean, there's no point over treating ovaries that are not responding, in my opinion, because especially if we've tried it and it hasn't worked. So I would try this. If that failed, then I would move on to completely natural cycles. And if that failed, then I would probably consider egg donation. So in my opinion, it's too many IVF cycles if we use the same thing over and over and over again. We don't expect a different outcome if we use the same thing. That's my motto. So I don't know if I helped.
Okay. Thank you so much for your advice here. And let's move on to the next question, next patient from. Okay, so here's the question. So I would like to ask, what would you suggest for recurrent implantation failure? Biopsy, laparoscopy, ERA, NK, thrombophilia, thyroid tests were done. Total of 14 embryos transfer, 4 PGT tested, 2 blastocysts. I'm 41, trying since I was 34, 4 clinics, 3 countries. And are you still working at a Greek clinic?
Sure. Yes. Hi, Zelika. Okay. Okay. Definitely not ERA. I mean, I've never used ERA, and it seems that the evidence now is not supporting its use. Everything else, yes. Hysteroscopy, laparoscopy to exclude infections or endometriosis. Thrombophilia, definitely. Thyroid test, definitely. NK cells, maybe. I would, to be honest, I would. But, we're a little bit skeptical about the outcome and the interpretation of the results. Definitely PGT testing. Microbiome, definitely. I would look into sperm carefully. I mean, even if sperm is entirely normal, I would still look into some factors on the sperm, so karyotype, cystic fibrosis. On the male partner, I would do a standard Wellman check, like prolactin, thyroid, vitamin D levels, glucose. DNA fragmentation in ICSI hasn't proven anything, but I would maybe I would consider it. I mean, I would dig a little bit deeper into investigating the man. Definitely a semen culture. Definitely ICSI in the lab. Any sort of technique that would maybe increase the chance in the lab. I mean, at 41, yeah, this is challenging. I mean, so many attempts, so many embryos. Definitely hysteroscopy, microbiome. Yeah, I think that's for now. But certainly, yeah, PGTA I would use. As long as you produce embryos, in theory, you can get pregnant. But then I would look into the protocols. Which is the most effective protocol? Perhaps, adding a little bit of LH, in the cycle. Proper stimulation. I mean, stimulation is an art, in my opinion, and unfortunately, sometimes we have scanty information on the stimulation cycle. We have the scan result. We don't have the hormone results. Some people claim that it doesn't matter really. You use a fixed protocol and that's it. It doesn't make any difference. Even research supports that, which is fair enough, but not for the individual patient, not for perhaps you. It's so yeah, keep going, Zelik. I mean, I wouldn't give up on you. I mean, in the meantime, stay healthy. Check your breasts and have your HPV DNA on the cervix. Keep going. I mean, as long as you produce embryos, and 41 is a reasonable age. At some stage, of course, we draw the line. But if you have a little bit more strength, physical and emotional, I would try a little bit more. Yeah.
Okay, thank you so much. And of course, as always, best of luck. Let's go to the next question from a different patient again. So what is the impact of BMI on IVF protocol? Does the medication get more diluted so it is less effective in terms of stimulation? Could you explain this a bit more?
Yeah, sure. Absolutely, Daphne. I mean, most drugs, if you look into the instructions of use, they mention the dosage per kilo. Okay, so it's a different dose of drug we would give to a 45-year-old, and a different dose we would give to a 45 kilo woman, compared to a 100 kilo woman. So yes, it has to do with the overall size, and equally some certain drugs, for example, like the long-acting FSH, Elonva, has different dosage, 100 to 150, depending on whether someone is above or below 60 kilos. So yes, absolutely. Absolutely, it has to do with weight.
Okay, thank you for the
Weight
confirmation
as well
here.
as other factors, of course, as well as age, as well as AFC, AMH, previous response to stimulation, and so forth. So, I mean, we're aiming at effective stimulation. In my opinion, that's the bottom line. To try, if someone is starting first time, we need to try and identify what's the best dosage and what's the best composition of drug we need to give to them. If someone has tried before, then we draw upon the experience that we've gained from the previous cycle, be it in our unit or in somebody else's unit. Now, a common issue, of course, is whether we go step up or step down. And we find that especially in women especially in hyper responders, sometimes we'll a little bit mess up with the stimulation, especially if we fear hyperstimulation and we employ step down protocol, especially in the antagonist. So I think we have to be very careful there, and it's very important to get to have a meeting in the unit. In my opinion, every day. I mean, at Embryoclinic we have a meeting daily in order to discuss the cases. This is educational as well as business meeting, in order to ensure that everybody's understanding how we should be treating our patients and how important it is to sustain the follicular growth in battling our fears for hyperstimulation, which we can manage with other means rather than stepping down the dosage, especially on antagonist protocols. So many times we identify that the protocol stimulation has not been optimal, and this may have affected not only the quality, not only the number of eggs, but also the quality of the eggs and the chances of successful implantation.
All right, brilliant. Again, thank you so much. We will be slowly finishing, but there are a few questions. I think we can still have a look at them, right? So the question is here. So what about the treatment of oroplasma, which was found in a random culture of asymptomatic vaginal smear? Should we treat it? Should we treat it?
To be honest, yeah, uroplasma is not as bad as people thought it was, some time ago. On the other hand, in my practice, I treat it. Yeah, I treat it with simple antibiotics. More often than not, I treat the partner as well. But what I do not do is I do not retest, because it's been shown that it's adding on to the stress and the stigma and all that. So yeah, I would treat it and then just leave it alone, let it be. I mean, of course, there's a huge debate here because some people claim that, and maybe they're right, that it's part of normal flora. Of course, it has to do with symptoms. It has to do with the density, the amount of microorganisms identified and all that. But yes, I would generally I would treat it with a course of appropriate antibiotics.
Okay, crystal clear. Thank you so much. And let's go to the next question about hysteroscopy, actually. Okay. So, if you have had a hysteroscopy previously, do you need to repeat it? If I had one early in the fertility investigation, which did not indicate any problems apart from a small incidental polyp, but that was approximately 8-10 years ago. Since then, I have had 7 unsuccessful IVF, recently 2 donor egg cycles, now preparing for a 3rd donor egg cycle. I have had a endometrial biopsy last year, endometriosis, so Emma, Alice, etc. No problems detected. I need a repeat? Would I need to repeat hysteroscopy as now nearly
Sure.
48?
I think I mentioned before that, in my opinion, hysteroscopy is valid for, especially in women over 40, it's probably valid for a year and a half. So I would definitely repeat it.
Okay.
Yeah. In my opinion, we need a first hysteroscopy in order to ensure that there's nothing else happening in the meantime. What can happen? Polyps, adhesions, infections, endometritis, especially if in the meantime there's been a pregnancy, a miscarriage, or multiple failed implantations.
Okay. Again, thank you so much indeed for the clarification. Let's have a look at the question from Angela. So, have you any experience using tacrolimus for recurrent implantation failure, aiming to try this time around? Previously interrupted prednisolone without success.
No, I'm afraid, Angela, no experience.
Mm,
No,
okay.
I've never used it.
Mhm.
I've been looking into this, but I've never used it. I'm sorry, but I would be interested in your opinion and in your experience after you've used it.
Okay, thank you so much indeed. And there, I think that we can go ahead with 2 more questions. I do see that you have more questions, but of course, remember that we will be finishing for today. But don't worry, of course, we will be happy to forward any of your questions to Dr. Tsakos and his team at Embryoclinic. So I guess we can still have a look at this question from Nicola. So high thyroid antibodies always have been, but getting higher thyroid function blood tests within normal range. How would you approach that before or during IVF?
Sure. Hi, Nicola. Thank you so much for the question. I mean, there isn't very much we can do about high thyroid antibodies. All we can do, in my opinion, is prescribe a small dose of thyroxine, maybe 50 micrograms, depending on the response and all that, aiming to have a normal TSH. Now, what's a normal TSH is a long discussion. I mean, as you know, the normal range is up to 4. There is a little bit of discussion as to whether it should be 2.5, and unless it's 2.5, something terribly wrong is happening with this. I don't think it's that important. Keeping optimal TSH is important. What's an optimal TSH? Perhaps, under 3 is fine. But just remember that there's fluctuation of the TSH. But definitely, again, in my mind, the difference in the management and of course have an ultrasound scan of the thyroid. Okay, the difference in the management is pretty big between women, asymptomatic women with normal scan and normal thyroid hormones, TSH and high antibodies. Perhaps those women who are not wishing to get pregnant, we can just monitor without necessarily treating them with thyroxine. However, women aiming at fertility or undergoing assisted reproduction technology, in my opinion, they have to be under thyroxine just to ensure that at least the thyroid hormone level in their blood and the TSH is within normal range without over panicking. I mean, I'll never forget, about a year ago, I had, serious discussions and complaints by a patient who thought that 2.78 TSH was way out of range, and which is not the case if you have been on thyroxine, which I had been. So without panic, I think high antibodies, the evidence shows that we're very safe to treat them for women aiming for a baby, for pregnancy, either natural or assisted, regular checks of thyroid hormones and perhaps of the thyroid gland by scan, and standard dose, small dose of thyroxine, perhaps 50, not 25. 25 is placebo dose, in my opinion. It's too tiny. Perhaps 50 micrograms in order to sustain a normal thyroxine TSH levels of around, between 2.5 and 3. It doesn't mean if it's 3.25 something terrible happens. I mean, the level is up to 4. And of course, in pregnancy, there may be a cascade there. So keep testing and keep checking to ensure that you're well within the levels. And you may find that you may need to increase the thyroxine level depending on the results.
Okay. Thank you so much indeed for yet another question. And now we will go to our final question from Rebecca. So I think we can still answer this. So Rebecca would like to know, so I had two rounds of stems, only 7 follicles, 4 eggs, 8 follicles, 3 eggs. The first 3 fertilized, second 0 fertilized. Am I classed as a low responder? Would you change the protocol? I'm 41, have stage 4 endometriosis, and Crohn's disease.
Yeah. I mean, Rebecca, at the age of 41, this is normal response. It's not low response. And if you, together with endometriosis, this is pretty good going. Now, it's sad that is there a cat somewhere?
Sorry, yes, here.
Yeah, to be honest, in your case, I would evaluate the endometriosis. I mean, stage 4. What does that mean? I mean, has it been operated on? Is it there? Is it what? What is it? Is it a deep endo? Is it ovarian endo? I would be interested to find out what kind of endometriosis is. I mean, as you know, endometriosis and Crohn's disease, there's an indication of inflammation there, local or even general autoimmune challenge. So I would address that, definitely. I would address the endometriosis and maybe the Crohn's disease. This is normal response for your case. And I feel that it was just bad luck that your eggs didn't get fertilized second time around. So I would just keep going. I mean, obtaining 4 and 3 eggs in your case, 41-year-old with endometriosis and Crohn's disease is good going. So address your endometriosis and your Crohn's disease with a specialist, different specialist, and then perhaps have another go. I would use the protocol that produced 7 follicles. And if it's the same that you use the second time, perhaps it was a bad cycle.
Okay. Thank you so much indeed. And as you can see, Rebecca would like to say thanks. But also some previous patients definitely would like to say thank you for everything that you helped with today, of course. And I'm sorry, my cat is really hungry, I guess. Sorry about this. But thank you so much, everyone, for joining. It's been great. And thank you for your patience. I'm glad that we were able to be here and of course explain this topic, and thank you for your questions, and I'm sure it was really helpful for you. Dr. Tsakos, always a pleasure. So I'm glad that we made it, and we've been able to work this out. Before we finish, is there anything else you would like to add? As always, of course.
Well, I'd like to thank everyone. Thank you for waiting. Thank you for your comments. Thank you, Mr. Dave, as always. Photios, thank you. I mean, Caroline, what you're doing with the European Fertility Society is amazing. Not only are you helping patients all over the world, but you're also helping us. You're keeping us on our toes. You're keeping us stimulated and motivated. Thank you. All I have to say is that this is an amazing resource. I'm glad I'm part of it, and I'm a huge fan of the platforms, and hopefully I will continue sharing
Definitely.
what I know, what I don't know, my visions. We don't stop. We keep going. We keep exploring. We keep studying. We keep questioning and challenging ourselves and the previous knowledge in order to build a new one. Thank you, everyone.
Definitely.
Have a lovely evening.
Definitely. Thank you so much, Dr. Tsakos. Always great to have you for sure. And we will definitely continue to educate everyone. And thank you so much, everyone, for joining us over and over again. This is our third webinar actually this week. And as you know, we will be back tomorrow. So please stay tuned. There are more events coming up. So thank you so much, everyone. And of course, tomorrow we will talk about PGTA. So if this is something that you find interesting and would like to ask some questions, go ahead, register, and we'll be here tomorrow at 7 p.m. UK time, of course. And Dr. Tsako, as always, thank you so much. Looking forward to some more events with you, and I know it's gonna be an interesting session. So thank you so much, and take care. Good night, everyone. Take care. Bye.
Good night, everyone. Thank you.
Bye.